Hello, ladies and gentlemen. Welcome to this lecture where we are going to be talking about pathophysiology, and we shall talk about the introductory bits of pathophysiology. Now, in this lecture, you should be able to know what the word pathophysiology means. You should be able to define the word pathophysiology. You should be able to know how cells respond to injury. And we need you to differentiate between the two words, pathology and pathophysiology. And then you should also be able to know how cells respond to edema. Yeah. Now, the word pathophysiology basically comes from two words. One of them is physiology. And then it also comes from the word patho. So those two words make up the word pathophysiology. So first, we shall define the word physiology, and it basically deals with how the body functions. Yeah. So it is the study of vital processes that basically take place within the body. Now, pathology or patho is basically something abnormal. Yes, so when you study the abnormality or what is abnormal as far as the processes that are taking place are concerned, it is referred to as pathophysiology. Now, you need also to differentiate those two words, pathology and pathophysiology. Now, pathology basically deals with structural changes, yeah? Structural and functional changes, you know, leading to disease, yeah? And these can be in a cell, in a tissue, and or in an organism, or in an organ. And pathologists are basically specialized people who you first do your years in medicine and basic sciences, and then you go for specialization in pathology. And the people who do pathology are referred to as pathologists. These are the people who are engaged in postmortem, in diagnosing, like for example, cancer and all those things, yeah? Now, pathophysiology, this one is the study of how diseases alter the normal function, yeah? In other words, they change the normal physiology of the body. And so that is basically, or it becomes abnormal, yeah? So, and with pathology, this is a science that basically is studied all across the medical field, yeah? And so it is very important that you nurses should basically do it, because it is very, very essential and relevant as you study. Now, these are the terms that you will find that are related to what we are studying. First of all, pathology, which we have defined already, things like pathogenesis, etiology, which is basically the study of cause of disease, things like idiopathic, things like iatrogenic, clinical manifestations. All these terms you're going to come across as we discuss this pathophysiology throughout this semester. And when you find such a word, please, you should know the meaning. Yes, diagnosis, prognosis. You should know what it exactly means. Yeah, because if you don't know what exactly it means, then you're bound to go wrong. So please acquaint yourself with such definition and terms as we move on. You will be able to get used to them. Now, we want to know how cells respond to injury, yeah? So that basically means that a cell can be injured, yeah? And if a cell is injured, then there is a response, yeah? Just like you can be cut, yeah? Your body can be cut. And how do you respond to that cut? How does it really happen? Now, cells also can respond to injury. Remember, we know that a cell is the smallest living unit of a human being, yeah? And these ones also respond to injury, yeah? So we are going to see that cells respond to injury in different ways, yeah? We have things like hypertrophy, things like atrophy, among others that we are going to look at. So you're going to realize that cells respond to injury in different ways, depending on where that cell is situated or depending on the fate of that cell. So we should talk about what we call cellular adaptation. And basically, cells, tissues, organs, and organ systems can adapt, to both normal and what we call injurious conditions. In other words, a disastrous condition. Yeah. So an adaptation is basically an alteration to an external stressor. Yeah. So there is a change in function and structure of a cell as far as change in growth. Like, for example, we have the uterus. Yeah. When a mother is pregnant, the size of the uterus is not the same as the size when the mother is not pregnant. Yeah, things like dilatation of the left ventricle. Yeah, after a myocardial infarction, all these are changes. Yeah, and we refer to that as adaptation. Now, types of cellular adaptations. The very first one that we have is what we call atrophy. And atrophy basically refers to a change, yeah, in size, yeah, and it is basically a decreased size resulting from decreased workload, yeah. You know very well that if a muscle is not utilized, yeah, for some time, then it atrophies. So in other words, the cells shrink, they change in size, and as a result, you have it, becoming small. Yeah. We also have examples like the brain, things like secondary sex organs, things like the heart. Yeah. All these can atrophy if if in case there is a decreased kind of workload. Now, atrophy can be classified as physiological or pathological. So we are saying atrophy can be classified as physiological or it can be classified as pathological. So we are going to see the different why we refer to it as physiological or why we refer to it as pathological. Now, physiological atrophy, this one basically occurs in early development. Like, for example, the thymus gland. Now, the thymus gland is located around the neck, yeah. And in children, however, adults do not have it. Why? Because it's no longer of use. Yeah. So basically, what happens is that it atrophies. Yeah. It atrophies, and as a result, it basically shrinks. Yeah, and is no longer functional. Yeah. So that is an example of a physiologic atrophy. On the other hand, pathological atrophy, this one occurs, like, for example, as a result of decrease in workload, things like, use, pressure, blood supply, decrease in nutrition, hormonal stimulation, and also decrease in nervous stimulation. A very good example here is like in polio. You see that someone with polio basically have one leg smaller than the functional leg. The reason here is because of the decrease in nervous stimulation. Yeah, and as a result, it atrophies, yeah? So that is what we refer to as pathologic atrophy. Now, another good example is that individuals, people who are bedridden, yeah, for a very long time, like for example, patients who are in ICU, yeah, their muscles, their skeletal muscles, or whether of the feet or the hands, they tend to atrophy, a phenomenon that we refer to as disuse atrophy, because they are not actually using these structures, and as a result, it basically atrophies. Right now, below is a diagram of exactly what you see. Above is the normal, yeah, the normal structure of the cells, and when they atrophy, you can see that they basically change in size, yeah, they reduce in size, yeah, and as a result, we refer to that as atrophy. So they will reduce, in size, as you can see on the slide there. That's what they have reduced in size. Now that is what we refer to as atrophy. Now the second one that you need to know about is what we refer to as hyper. The word hyper basically means to increase, yeah? The word hyper basically means increase in size, yeah? So what actually happens is that with hypertrophy, there is an increase in cell size resulting from increased workload. Remember, we said with atrophy, it is as a result of decreased workload, decreased nervous stimulation, decreased hormonal stimulation, among others. With hypertrophy, the word is increase in cell size, yeah? And it results from an increased workload. Now, a very good example of this is basically the heart, yeah? Like, for example, patients who are hypertensive, as we shall see, they have left ventricular hypertrophy because of the increased activity of the heart, leading to left ventricular hypertrophy. Now, other cells that are basically responsive to such kind of increase in cell size are the cells of the kidneys, yeah? Now, this one can also be classified as physiologic and or pathologic. Now, pathologic hypertrophy, this one is usually secondary to things like hypertension, valvular dysfunction, and which all eventually leads to what we refer to as myocardial failure, or what we refer to as MI, yeah, or leading to what we refer to as either heart failure. Now, so this is pathologic. And on the other hand, with physiologic hypertrophy, we have it, like, for example, during postnatal development, things like during training, you know, when mothers, rather when sports people are trained, they basically their heart muscle can atrophy, rather hypertrophy, or even during pregnancy, where we have things like the uterus, you know, the cells increasing in size, yeah, to kind of like give room or provide enough to accommodate the growing baby. And as you can see, you have the normal and then you have the hypertrophy. With hypertrophy, you can see there is basically an increase in cell size. Now, other types of cellular adaptations, we have things like hyperplasia. Remember, we said with hyper, it basically means increase. So with hyperplasia, we are talking about the number, yeah, the number of cells, yeah, resulting from an increased rate of cellular division. You know that cells really divide, yeah. Cells they divide by the process of mitosis. So if there is an increased number of cells resulting from increased rate of cellular division, we refer to that as hyperplasia. Now, hyperplasia can occur as a response to, to injury, yeah? And usually occurs when the injury has been severe or when it is basically prolonged. There is what we call normal hyperplasia, and then there's also what we call pathologic. So we are saying there's what we call normal, and then there's what we call pathologic. Pathologic hyperplasia. Now, normal hyperplasia can be compensatory or hormonal, yeah? And with compensatory, this one basically occurs in epidermal and intestinal epithelia. It can occur in hepatocytes, bones, fibroblast cells, bone marrow, And so hormonal hyperplasia occurs chiefly as a result of, estrogen, yeah? And things like, for example, within the uterus, that when a mother becomes pregnant, yeah, there's too much estrogen in blood supply, yeah? So as a result, it facilitates the uterus to, to be able to accommodate the growing fetus. Same applies with the breasts, yeah, in lactating mothers, yeah? And also when it is called pathologic, when it is basically abnormal proliferation of normal cells, and can usually occur as a response to growth of cells, yeah, and usually it occurs as a result of hormonal stimulation, and also too much stimulation by estrogen can basically be disastrous, yeah. So that in that way it becomes pathologic. Now we also have what we refer to as dysplasia. And with dysplasia, it basically means abnormal change in cell size, shape, appearance, and organization. I want you to note those words, yeah? So we are saying cell size, we are saying shape, we are saying appearance, and also we are saying organization. So with dysplasia, it is basically those 1, 2, 3, 4 things, yeah? Size, shape, appearance, and organization. So in other words, the cells do not basically look the same. They have changed in shape from the normal shape. They have changed in appearance, So just like the word itself, this is not a normal thing, right? It's not a normal thing. Actually, it is often referred to as atypical hyperplasia. And this can be frequently seen in the epithelium of the cervix when mothers go for, cervical counseling or for cervical screening for cancer. It can also be seen in the respiratory tract, yeah? And it can be classified as mild, moderate, or severe. With mild, it basically means there's not too much change in shape, size, and appearance. While with severe, it basically means there is too much change in size, shape, appearance, and organization of the cells, to the extent that in most cases it is indicative of cancer. Yeah, if it happens, in most cases, dysplasia is indicative of cancer. Now, we also have what we call metaplasia. And this one is basically replacement of one cell type by another, yeah? And usually that is not normal, yeah? You know that when you replace the cells, like for example, the epithelium of the skin, when you replace it by another cell type, it will not be able to perform the way that the normal cell type functions, yeah? Or if you have within the airway or the bronchial tree, when you replace those columinous ciliated epithelium, yeah, and you replace them with other types of cells, then they will not be able to perform their function, And as a result, it is not, it's not a good thing. Yeah. So if there is replacement of the normal cells by another type of cells, yeah, it's not usually normal. And in most cases, it is also indicative of cancer or developing cancer. And as you can see dysplasia and metaplasia. As you can see here, basically there is a change from the stratified columnar to a different kind of cells. Yeah, and as a result, it is not good. Now, we also know we want to talk about what basically causes cellular injury. Yeah. So cellular injury is caused by several factors. Yeah. And some of these factors can be hypoxia, chemicals, infections, things like inflammation or immunologic agents, things like physical agents, nutrition imbalances, genetic factors, among others. So these bring about, cellular injury. And when they bring about cellular injury, then the cell adapts, the cell makes a transformation from what we have seen earlier, the atrophy or hypertrophy, among others. Yeah, so these are some of the causative things that bring about cells to change, yeah, as a result of injury. Now, what do you see? What is basically seen while you might have a cut on your body, and we see that indeed you're bleeding? Yeah. Now, what shows that a cell has been injured? Yeah, that is what we refer to as the manifestation of cellular injury. Now, when cells are injured, there's what we call cellular swelling. Yeah, it is very common that, I imagine this is our cell. Imagine that is our cell. You know very well that a cell has what we call a cell membrane. Cell membrane. Yeah. So if it has a cell membrane, now ideally in a normal cell, that cell membrane is supposed to be intact. Yeah. And you know very well that if you're doing anatomy, the cell membrane is basically a lipid bilayer, yeah, which is very, very intact. And one of the pumps, now this cell membrane has several receptors and several pathways, yeah, leading to the inside of the cell. Like, for example, this is the nucleus, yeah, and then this is the cytoplasm of the cell. Now that cell has several channels along the cell membrane, and several receptors are expressed along the cell membrane. Now, when there's injury to this cell as a result of the factors that we have talked about, what actually happens is that the very first barrier that is destroyed, or the very first barrier that is attacked on a cell, is the cell membrane. Just like you can get burnt, yeah, and the very first barrier of your body that is attacked is basically the skin. So in the same way, when a cell is injured, the very first item of the cell, or the very first structure of the cell that is injured, is what we refer to as the cell membrane. The cell membrane. Now, when that cell membrane is injured, you know very well that there are some processes or physiological pumps that function on this cell membrane, and one of them is what we refer to as the sodium-potassium pump, called sodium-potassium pump. Now, when that pump, when that sodium-potassium pump is injured, what actually happens or what you should know is that sodium is basically an extracellular ion. Sodium is an extracellular ion. Extracellular ion. So sodium is extracellular. While potassium is an intracellular. It's an intracellular ion. Now, ideally, in the normal physiology, what actually happens is that this pump, like for example, this pump might be located around here, and what it actually does, it pumps sodium out while it brings potassium inside, yeah? So this is the potassium. So ideally, since potassium is an intracellular ion, it pumps, that sodium potassium pumps potassium from the from the extracellular, like for example, from the interstitial space inside the cell. And it pumps sodium out of the cell. Now, you know what happens? When a cell is injured, what actually happens is that this pump no longer functions, yeah? So when a cell is injured, this pump no longer functions. And what actually happens? What happens is that once it no longer functions, what actually happens is that the sodium will rush to come inside. The sodium will rush to come inside, while the potassium will rush to go out. But because sodium is high in the extracellular and it is concentrated in the extracellular, for that matter, when it comes inside, water follows. Yeah, a very good concept that you should learn is that when sodium, wherever sodium goes, water follows. And as a result, since sodium is coming inside, water will also follow inside, resulting into cellular swelling. In other words, the cell will swell. The cell will swell because of the too much water. Yeah, the cell will swell, and therefore it will end up bursting. Yeah. Now that is one of the manifestations of cellular injury, and and basically the reason is that inability to maintain a stable extracellular and intracellular fluid electrolyte balance. Now that is the physiology of what happens. Yeah. Now the other manifestation of cellular injury is what we refer to as fatty change. The other manifestation of cellular injury is what we refer to as fatty change. Now, this is very evident. Basically, by fatty, we refer to lipids, yeah? And this is common, or it basically occurs in the vascular organs, like for example, in the liver, yeah? When there is any kind of injury like maybe to the liver cells, just imagine this is our liver cell, and there is injury to it, yeah? There's injury. So what actually happens is that fat enters, yeah? Fat enters these cells, yeah? And then, and if there is too much deposition of fat, that basically means that the cell will not be able to perform, the vital functions that it is supposed to perform. Like for example, the hepatocytes within the liver are responsible for things like metabolism. Now, if there is too much as a result of injury to the hepatocytes, and fat enters into the cell, it becomes too much to the extent that it interferes with the normal vital function of these cells. And if for example, if there are hepatocytes of the liver, then we find things like a fatty liver, yeah, and you know, it is unable to do or to perform its role of metabolism. So basically, that is what we refer to as fatty change. Now, there is also what we call cell death. Now, with cell death, it is basically two. It can be two of two types. There's what we call apoptosis. Now, with apoptosis, this is basically programmed cell death. Now, you know very well that there are some cells within our bodies that are supposed to live for a specific period of time. Like, for example, the red blood cells. Yeah, red blood cells. Red blood cells are supposed to live for a period of 120 days. Yeah. So and also we have platelets which actually live for less than that. Yeah. We also have white blood cells which also live for less than that. Now, within the genetic makeup, yeah, of these cells, or within our genetic makeup, there is a program that is ideally supposed to destroy or kill these cells after the destined period of time for which they were supposed to live. And that is what we refer to as apoptosis. So basically, within a cell, we have things like liver enzymes, not liver enzymes, but cell enzymes like lysosomes. These organelles are responsible for destruction of self-destruction of these cells when their time comes. Yeah. So that is what we refer to as you know, apoptosis. Now, so and if it is damaged, yeah, before its time, again, it will have to, you know, to die. So what actually happens is that the injured cell releases enzymes that engulf and destroy, you know, the cell itself. Yeah. So the cell shrinks, and then what actually happens is that when the cell shrinks and it dies off, then we have other cells like the macrophages and the neutrophils engulfing them. Now we have what we refer to as necrosis. Necrosis, this is basically pathological, right? It's not a normal. Well, apoptosis is normal. Yeah, in other words, it's programmed. With necrosis is basically pathological, and it basically involves a cell swelling, as we saw last time, as we have just seen, and then after that it basically ruptures. There are types of necrosis which I want you to go and read about: coagulative, liquefactive, caseous, and fatty. Please read about these types of necrosis. Yeah. Now, the other last thing that we want to talk about is basically, you know, what we call or refer to as extracellular edema. Now, when cells are injured or when there is some kind of inflammation to our body, what actually happens is that we realize some form of swelling in that area. Yeah, and this is what we basically refer to as edema. Now, I want you to follow along with me to really understand this concept of extracellular edema, yeah, so that you basically have a clue. Now, imagine this is our blood vessel. Remember, we have the blood, we have the capillary, yeah. Then it basically ends up forming the capillaries, yeah, and then it ends up with the venules, yeah. So just imagine this is our arteriole, then the capillary, and then the venule, yeah. The venule is where things will eventually end up into. Now, and then these are our cells. Below here our cells that need to be perfused. Yeah, what we call the parenchymal cells. Yeah, we have the parenchymal cells here. Now, when there is injury, remember blood is coming in that direction. Yeah, and then also it is going in that direction. Yeah. Now, when there is injury, maybe let's first talk about the normal. What actually happens in the normal? Now, normally, we have two pressures that are always in balance. Yeah, one pressure is called the plasma oncotic pressure. And then we also have what we refer to as the hydrostatic pressures. Now, those two pressures in a normal person or normally they're in balance. What actually the oncotic pressure does is that it wants to maintain the blood within the bloodstream. Yeah. So it wants to maintain this blood within the vesicular stream. That is what we refer to as the oncotic or the plasma oncotic pressure. Yeah, this one wants to maintain the blood within the bloodstream. Yeah, oncotic pressure, OP. Yeah, while the hydrostatic pressure, this is the pressure that is exerted as a result of of the blood itself. Yeah, and it is basically downward. It is affected or too much affected by gravity. So what actually happens is that the hydrostatic pressure, for it wants blood to leave the vesicular component, in order to leave the vessel. Yeah. Now, what actually happens is that at the arterial side, the oncotic pressure is greater than the hydrostatic pressure. Yeah. So at the arterial side, the oncotic pressure is greater than the hydrostatic pressure. However, as the blood moves towards the capillaries, yeah, the hydrostatic pressure exceeds the oncotic pressure. And as a result, because of that, then blood seeps out of the capillaries to the interstitium, to the interstitial space. We call this the interstitial space. So at the capillary level, what actually happens is that the hydrostatic pressure is higher than the oncotic pressure. And as a result, blood leaves the capillaries into the interstitial space to bathe the individual cells, in order to provide the individual cells with things like oxygen, nourishment, and whatever. Now, as it goes towards the venule side, what actually happens is that again we have the oncotic pressure, yeah, being higher than the hydrostatic pressure. So basically that is what happens in the normal. And so after bathing here, the blood returns, yeah, it returns towards this side. It basically returns back to the venules and to the major veins, and then back to the heart, yeah. And the rest of the fluid that is not taken by the venule is usually taken back by vessels which we refer to as the lymphatic vessels. So the remaining fluid that remains and it is not taken back to the venules is basically taken back by the lymphatic vessels. Now, this is what happens in the normal circumstance or in the normal situation. Now, when there is injury or when there is inflammation, things happen slightly differently, yeah, leading to what we refer to as extracellular edema. Now, what actually happens is that, again, because of inflammation, we shall look at inflammation. We know that because of inflammation, what actually happens because of the several mediators, cellular mediators that are released, there is a dilatation, yeah? There is a dilatation. In other words, this arteriole dilates, it enlarges in size, yeah? And as a result, there is too much blood coming towards that area, yeah, where there is inflammation or where there is injury. And so what happens is that at this area, we have what we call endothelial cells, yeah. They are what we call endothelial cells. So if I can draw them like that, endothelial cells. Now, during inflammation or during injury, what actually happens is that these endothelial cells retract, yeah? In other words, they become smaller to create spaces within them, yeah? So things like these spaces, yeah? So what actually happens is that too much fluid, yeah? Too much fluid leaves, yeah? Too much fluid leaves the capillaries via these spaces, yeah? Too much fluid leaves the capillaries via these spaces, and you have a lot of fluid, yeah? You have a lot of fluid here, yeah? And as a result, because of the too much fluid that basically leaks into the interstitial space, you tend to have edema, yeah? You tend to have what we refer to as edema because of the too much fluid that has leaked out of remember this fluid also contains plasma proteins, yeah, like albumin. And albumin is one of the proteins that is known to contribute to oncotic pressure. So if albumin leaves, it will still attract more fluid, yeah. So in other words, you'll have a lot of fluid within the interstitial space, and therefore you will end up with what we refer to as extracellular edema. Now, it is also very important for you to know that, or to differentiate the two terms. There is what we call pitting edema, and there is what we call non-pitting edema. Now, the difference between those two types of edema is depending on, or it depends on the patency of the lymphatic vessel, yeah? Now, with pitting edema, the process is still the same, and the vessel is basically patent. The lymphatic vessels are patent. So that basically means that when you touch someone's body where there is edema, there is basically you can leave you can leave kind of like a groove. What do we call it? Something goes inside, yeah, and in indulation, yeah. You may leave an induration with pitting edema. However, with non-pitting edema, when you touch, when you touch that edematous area, then you do not get an induration, or there is no depression, yeah. What actually happens, or the reason behind there, is that with non-pitting edema, what actually happens is that the lymphatic vessels have been damaged, yeah. The lymphatic vessels have been damaged, and for that case, when you touch, that fluid does not tend to move, yeah, because of the damage of the lymphatic vessels, yeah. So this is evident in people who have elephantiasis. I don't know whether you've heard about elephantiasis. The Filaria worms that are responsible for causing elephantiasis, they basically attack the lymphatic vessels in that area. And as a result, the patient will have non-pitting kind of edema. Now, I hope you have understood the mechanism of how extracellular edema comes about. Once again, we said that if there is inflammation, there is a dilatation of the arterioles, therefore it is bringing in too much blood, yeah? And at the same time, because of the damage and because of the release of the cells, the different mediators, there is the endothelial cells at the capillaries, they basically, they retract or bringing spaces within them, and so much fluid leaks out, yeah? And as a result, you will have, you know, too much fluid within the interstitial space, bringing about what we refer to as extracellular edema. Now, we have talked about this, a decrease in plasma colloid osmotic pressure, an increase in hydrostatic pressure, an increase in capillary permeability. This is what we refer to as the capillary permeability. In other words, you know, the capillary, the cells, the endothelial cells of the capillaries, they become more permeable, and as a result, there is too much fluid, which basically leaks out from the vessels. Now, we said that edema can also cause or bring about dehydration. Yeah. Remember, the fluid that leaks out of here is not important. Yeah, it does not work. In case of edema, it does not play part in any physiological functions. Yeah, that basically means that the fluid that stays here is not enough. Yeah, in other words, the fluid that remains within the vessels, yeah, is not enough, and for that result, it will bring about dehydration. Yeah, so for that case, that is why it is important to always rehydrate people who have got burns. You have seen, I guess you have seen this in the hospitals, whereby people who have got burns are always given, you know, they are given fluids. The issue is you know, because fluid has leaked out into the interstitial space, is no longer useful. What remains in the vascular system is very little that it can bring about conditions like shock. That is why we give them more fluids, or that is why we rehydrate them, because they are dehydrated. Now, that has been that presentation. Please endeavor to get this and read critically. In case of any more information that you require, read critically and refer to the book that has been given to you. Other than that, please access this video for yourself so that you can understand the notes that were uploaded. Thank you.